In optometry practices across the country, revenue is quietly slipping away. This steady loss rarely has anything to do with clinical execution. It happens because the administrative framework supporting the doctors is stretched to its absolute limit. The financial damage stems directly from an under-resourced billing operation. According to the Optum 2024 Denials Index, 84% of these claim denials are preventable. The average healthcare claim denial rate climbed to 11.81% in 2024, representing massive uncollected cash. The gold segment represents structural failures within a practice's control. Isolating these preventable errors reveals that 44% begin with front-end registration and eligibility checks. Nearly half of a practice's denied revenue is effectively lost before the patient ever steps foot in the examination room. The financial penalty for these administrative gaps is severe. Failing to capture a single complex care add-on code like G2211 costs an average practice roughly $19,572 in legitimate reimbursements annually. Excellent clinical care is undermined if the administrative framework at the front desk is mathematically guaranteed to leak cash. Optometry sits at a specific crossroads in healthcare. Practice owners are forced to navigate two separate insurance coverage systems simultaneously. The initial data capture happens here, in a fast-paced clinical environment, well before the records reach the back office. First, there is the medical insurance side, which covers medically necessary conditions like glaucoma, diabetic retinopathy, and macular degeneration. Directly opposed to the medical side are vision insurance plans, like VSP or IMED, covering routine exams and eyewear. Front desk staff must determine which plan to bill first for a specific encounter, often relying on shifting, complex payer rules. Staff must also know exactly when to issue an advance beneficiary notice if a service falls into the coverage gap between both intersecting plans. Optometry practices effectively run two specialized billing operations at the same time. This dual structure increases the margin for front-end errors. When front-end eligibility issues bleed into back-end coding, the results are predictable. Industry data shows that operations lacking a dedicated specialty infrastructure average a 5 to 7% error rate on their submitted claims. In a high-volume practice where individual claim values typically range from $150 to $300 per encounter, those errors compound into serious financial deficits. The first major back-end trap is modifier usage. Staff routinely miss or incorrectly apply modifier 25 and modifier 59 when billing an evaluation service and a procedure on the same date. Here we see two distinct coding families mapped out. Practices must cleanly distinguish between the 920 series eye examination codes and the 992 series evaluation and management office visit codes. Choosing the wrong code family on a routine basis triggers an automatic denial from the payer. Another frequent failure point is neglecting to document medical necessity for expensive diagnostic testing, specifically OCT imaging. Billers also consistently trap themselves by filing routine retentions under medical codes instead of properly categorizing them as patient pay services. Routinely choosing the wrong code family delays cash flow and creates a permanent, easily detectable audit footprint. We can see the consequences of that audit footprint in nursing facilities, where high-complexity evaluation and management billing is heavily utilized. In December 2025, the Office of Inspector General completed a targeted audit of 15 optometrists providing services in these specific facilities. This alert dashboard displays the findings. 100% of the sampled high-level E&M services failed to meet Medicare requirements. Investigators found that conditions as routine as dry or itchy eyes were being billed under high-complexity codes 99309 and 99310. The financial consequence of this specific coding failure resulted in an estimated $3,059,204 in Medicare overpayments across just 15 providers. While audit scrutiny intensifies, practice owners face a secondary pressure. The Centers for Medicare and Medicaid Services slashed the 2025 conversion factor down to $32.35. That 2.83% cut directly reduces the available revenue on core optometry codes like 92014 and 99214. Practice margins are caught between the dual forces of plummeting Medicare reimbursements and aggressive CMS coding scrutiny. The standard response is hiring an internal billing specialist, but that approach introduces operational vulnerability when a team member suddenly resigns. MGMA data dive statistics show a 40% turnover rate for front office support staff. The turnover rate for dedicated billing and business operations staff sits at 33.3%. When a biller leaves, the practice loses critical institutional knowledge. The nuanced rules for dual plan billing and payer-specific modifiers walk out the door with them. This chart breaks down the true economic cost of an in-house biller. It stacks base salary, payroll taxes, benefits, and practice management software. The fully loaded annual cost of a single specialist routinely hits between $60,000 and $140,000. Even at that cost, internal staff rarely have the time or budget to complete ongoing specialty training, as CPT rules and CMS guidelines constantly change. Internal billing creates an illusion of control. In reality, it masks a cycle of creeping error rates and spiraling overhead that most practices cannot afford. High-performing practices are solving this margin squeeze by outsourcing their revenue cycle to dedicated billing companies. The critical differentiator of a successful outsourcing model is the requirement for AAPC and AHEMA credentialed specialists who possess day-to-day optometry experience. The most effective teams use native EMR integration. They work directly inside the software system your practice already uses. This creates a controlled, highly efficient digital workspace that completely replaces the chaos of an understaffed back office. This native integration supports major platforms, including Epic, Athena, NextGen, eClinicalWorks, and Creo. Working inside your existing system eliminates manual data transfers and resolves the front-end eligibility blind spots that cost $44. You eliminate the $60,000 to $140,000 in-house burden, replacing it with a fixed rate of $399 per week per seat through Staffingly. For high-volume practices adding multiple billing positions, volume pricing reduces that cost even further to $349 per week. The infrastructure is secure, operating under strict SOC 2 Type 2, ISO 27001, HIPAA, and HITRUS certifications. It also provides operational freedom. The engagement begins with a 14-day risk-free pilot and converts to a month-to-month structure with 0 long-term contracts. This model is currently trusted by more than 800 practices across the country to maintain sub-1% error rates. It is time to stop the leak. Book a demo today to analyze your own billing metrics. Transitioning from generalist internal staffing to a specialized credentialed infrastructure provides the scale and accuracy needed to finally plug those 84% preventable revenue leaks.